Hi everyone, I'm Alex Sable-Smith. I am a fellowship-trained hospice and palliative care physician, and today we are going to be talking about disposition from the hospital to hospice. This is the first video in a series that I'm calling Disp-o-Rama. These videos are geared towards residents and other clinicians who take care of seriously ill patients in the hospital and face the challenging task of determining the best discharge disposition, or DISPO, for them. You've done amazing work stabilizing a patient's medical issues and symptoms. You've determined a patient's goals of care, but now what? This series of videos should help you gain a better understanding of the different disposition options as well as their limitations. In this video, I'll cover hospice care. Future videos will address long-term care, subacute rehabilitation, and home health. We won't dwell on the nuances of hospice eligibility here, but as a brief refresher, hospice is intended for patients who have a terminal illness with an estimated prognosis of 6 months or less if the disease runs its natural course. Hospice is a plan of care and set of services to support patients and their caregivers who choose to shift the priority of medical care to improving quality of life over the prolongation of life. What do I mean by plan of care and set of services? Plan of care essentially means that hospice is a philosophy that guides treatment. The philosophy is the prioritization of relieving physical and emotional suffering at the end of life. Nobody can predict all the different scenarios or contingencies that may arise in the end-of-life process for every patient. But as clinicians, we keep the goal of symptomatic relief in mind as we're choosing how to treat a hospice patient. I want to make a point here. Any clinician in any setting can support a hospice plan of care to some extent if that patient has chosen a comfort-focused plan, especially when it comes to relieving physical symptoms. However, many countries around the world, including here in the United States, we have multidisciplinary hospice teams that specialize in carrying out this plan of care. Here in the United States, we have specific regulations that say what professional services and supplies are available to patients who elect hospice care. That is what I mean by set of services. We'll get into specifics of that later. As always, I like to illustrate these points with a case. So this is a hypothetical case. This is Alfredo. He's a 73-year-old male with Parkinson's disease, coronary artery disease. He had a CABG 8 years ago, and a couple years ago had a diagnosis of colon cancer. 2 years ago, he underwent a partial colectomy and lymph node dissection, followed by adjuvant chemotherapy. He was getting along pretty well at home with the help of his longtime partner, Darren. However, over the last few months, Alfredo's been falling more and has been losing weight. He had an episode of aspiration pneumonia that was treated as an outpatient. He's now hospitalized for new left arm weakness. During this hospitalization, you diagnosed a metastatic lesion in his brain, and he was also found to have a new colonic mass and several metastatic lymph nodes. In a family meeting, he said, "I've lived a good life. I know my time is coming soon, and I want to spend my final days with Darren and my friends and be pain-free." Based on this goal of Alfredo's, you recommend hospice. Now, take a moment to consider the following question. Where can Alfredo receive hospice services? A, in his apartment. B, a nursing home. C, a hospice house or facility. D, all of the above. If you answered D, you're correct. With few exceptions, hospice services can be provided wherever the patient is. The vast majority of patients on hospice receive services in their own homes. However, if your home happens to be a nursing home, assisted living, or other facility, hospice services can be provided there. Some hospice agencies actually operate specific hospice facilities or hospice houses, but these are few and far between in the United States. Let's get back to the case. Alfredo wants to receive hospice at home, which is the most comfortable environment for him. He worries that as he gets weaker and weaker, he'll need a hospital bed, and is also worried that he won't be able to go to the bathroom on his own. Dignity and personal hygiene are really important to him, and he doesn't want his partner Darren to have to clean up after him if he soils himself. Darren asks if hospice can provide a hospital bed, and help with personal care. What do you think? So I want you to consider this. Which services and supplies will hospice provide? Select all that may apply. A hospital bed and durable medical equipment, up to 8 hours of personal care per day, limited intermittent personal care, or D, wound care. If you answered A, C, and D, you're correct. Let's take a look at what's included in hospice services. The minimum services that hospice provides are described and set forth in the Medicare hospice benefit. This was passed by Congress in the early 1980s. So in terms of skilled and professional services, hospice patients have access to a physician, nurse, and if needed, physical therapy, occupational therapy, speech and language pathology. They get supplies like medications, durable medical equipment, and oxygen, just to name a few. There's so-called unskilled services, including a home health aide, and very limited custodial care. And patients also have access to social work, chaplaincy, and volunteers. This is a pretty comprehensive list. Now you might have noticed that home health aide is included and asked if they could provide personal care to Alfredo. The answer is technically yes. Home health aides can assist in a very limited capacity from time to time with things like helping with a bath or light housekeeping. But think once a week for an hour or so. You can't rely on the hospice home health aide for daily custodial care. This is a good time to make the distinction between medical services and custodial care. Custodial care means assistance with the basic activities of daily living, things like bathing, toileting, feeding, grooming, dressing, and mobility. Hospice is focused on providing medical care, especially focused on symptom management from the terminal illness. Now, while hospice will provide many supplies necessary to assist with day-to-day custodial care, the actual human labor, the human assistance, is not really supplied by hospice. These services are considered unskilled because you don't need a professional degree. But let me tell you, being a caregiver requires a lot of skill. It's a big misnomer. As a rule of thumb in the United States, to get this custodial care, you either need to have a lot of money or very little money. Medicare and health insurance don't pay for custodial care. So you have to pay out of pocket or hire a caregiver or pay for a long-term care facility. This is expensive, at least $100,000 a year in many parts of the country. There are two alternatives. One is that family and friends can all pitch in and do the custodial care themselves. But for many reasons, this often isn't possible. The other alternative is to have very little money and thus qualify for Medicaid. This health insurance program for low-income individuals will pay for custodial care in facilities and to some extent in the home as well. The problem is, many people find themselves in a financial situation where they don't have enough money to pay for custodial care out of pocket, but have too much money to qualify for Medicaid. They're stuck in the middle. What happens in these situations is that people pay out of pocket until they exhaust their savings and then qualify for Medicaid. Fortunately, Alfredo has saved money for this specific situation. He's able to hire a caregiver to come to his and Darren's house for 8 hours per day to help with the custodial care. It costs $30 an hour, about $240 per day, but it's worth it in Alfredo's mind because Darren doesn't have to worry that much about personal care. Alfredo is discharged home from the hospital, and the hospice agency has arranged for a hospital bed, shower chair, and wheelchair to be delivered to his apartment, all of which are covered by the Medicare hospice benefit. The hospice nurse comes by twice a week to check in on Alfredo and deliver various medications. He does pretty well for a few weeks, but one night he wakes up with extreme pain in his abdomen. Darren gives him a few extra doses of pain medicine, but Alfredo throws it up. Darren's extremely worried and doesn't know what to do. He calls the hospice 24/7 advice line, and a nurse comes over to the house. The nurse tries administering rectal antiemetics and pain medication, but Alfredo keeps vomiting and his pain is not relieved. The hospice nurse is on the phone with the physician on duty, and is talking about admitting Alfredo to a hospice inpatient unit. But all the beds at that facility are now full, the facility where the hospice has contracted to admit patients. Darren, worried about his partner's pain and wanting immediate help, calls 911. As you might hear, there's actually an ambulance going by in the background. An ambulance takes Alfredo to the nearest hospital. Now imagine you're the emergency clinician and Alfredo arrives. What do you do? A. Start a morphine infusion since he's a hospice patient. B. Assume that since he shows up at the hospital, he no longer wants hospice and reverse his code status. C. Begin usual treatments with intent to acutely control the symptoms he's having. If you answered C, you're, of course, correct. Have you ever been working in the emergency room when a hospice patient arrives? It can be really confusing as a healthcare provider, especially since we assume that once a patient goes on hospice, they're not going to come back to the hospital. Though it is rare, it does happen. Many clinicians think, does this person not understand what hospice is? Why are they here? Why are they at the hospital? However, put yourself in Darren's shoes, or the caregiver's shoes. He was in crisis mode. All he wanted was for his loved one's symptoms to be controlled, and the needs weren't being met at home. This doesn't mean that hospice isn't wanted anymore. It usually just means that the hospice services weren't meeting the needs of the patient in the moment. So, in the ED, the clinician places an IV and administers some fluids, antiemetics, and IV opioids. Abdominal x-rays don't show a bowel obstruction, but did show a large stool burden in the colon. Alfredo, turns out, hadn't had a bowel movement in 7 days. After administration of laxatives and an enema, Alfredo was feeling much better. He was admitted overnight to the hospital, and though his constipation improved, he remained quite delirious and agitated. Darren doesn't think he can manage to take care of Alfredo at home anymore. The next day, the case manager, hospitalist, and Darren meet with the hospice liaison and arrange for admission to a nursing home that is contracted with the hospice under a general inpatient or GIP hospice level of care. Hospice will work on helping manage the delirium while on GIP. The hospice assures Darren that he won't have to pay for the days in the nursing home as long as Alfredo qualifies for GIP level care. Now, what is it that qualifies a patient for escalation in levels of hospice care? A. Intensity of symptom management needs. B. Intensity of custodial care needs. Or C. Either. If you said A, you're correct. Under Medicare guidelines, it's only symptom management needs that can justify escalation in level of hospice services. Now that Alfredo is admitted to the nursing home under GIP, hospice is going to cover the room and board and the custodial care needs, but only while symptom management needs justify general inpatient status. As a general rule, inpatient care on hospice is limited and intended to be limited in its duration. Now, if Alfredo's agitation is managed and GIP is no longer justified, Darren will have to take Alfredo back home or start paying for the room and board at the nursing home, which, as I said before, is quite costly. Back to the case, Alfredo stabilizes, though he's now bedbound and no longer eating. He doesn't qualify for general inpatient anymore because his symptoms are managed, and it's really mainly custodial care that he needs. The hospice physician thinks his prognosis is likely days to a week. Darren decides to continue paying the nursing home for custodial care at a rate of $325 per day. Hospice services are still in place, and the nurse visits daily and oversees medication management and wound care for a sacral ulcer that's now developed. On day 10, Alfredo dies peacefully with Darren at his side. The hospice social worker and chaplain call Darren and then periodically over the next 6 months to check in on him and see how his grieving process is going. He's grieving appropriately without signs of severe depression. Memorial service is attended by over 400 family members and friends. Here's some pearls from this case. Hospice does provide a lot of medical care and support at the end of life for patients, but it's only very limited in the amount of personal care, custodial care that it provides. Don't oversell hospice as providing a lot of custodial care. Like most medical services, hospice is extremely limited in this. That is helping patients stay clean, dressed, groomed, fed. A lot of medical professionals don't realize this, that it's not part of the hospice package and may unintentionally mislead patients and families. This custodial care is physically taxing labor, and families are often on the hook for doing the brunt of it, much to their surprise. When help is needed, it's often financially unattainable. It's really unfortunate that caregiving is so often needed desperately but not attainable for many families. The second takeaway is that while uncommon, hospice patients do from time to time seek care at the hospital. Even the best hospice providers can't manage every situation. Showing up to the hospital does not automatically mean the patient no longer wants hospice. Usually it means they're seeking emergency symptom management and can return to hospice wherever it was being delivered before. This is a schematic I created to show who does the majority of day-to-day caregiving for a hospice patient. It really varies by setting. And I've divided it up into 3 different settings here: home, hospice in assisted living, and hospice in a nursing home. The x-axis represents time, while the y-axis represents the totality of caregiving labor. Each color represents a different group of people: gray for the hospice staff, blue for family members or privately hired caregivers, and green for the staff of a facility. In the home setting, hospice provides a low level of baseline services with intermittent extra help, such as a health aide helping with a bath once a week or during symptom crises. This is represented by the gray peaks. In an assisted living facility, there's some staff to help with medication administration and some personal care. But again, usually family members or hired caregivers are needed if the patient needs a lot of extra custodial care. Hospice services can be delivered in these facilities, focusing on symptom management. Finally, in a long-term care setting, these places exist to provide custodial care. And so their staff are going to provide 100% of that custodial care. Hospice is still important in this setting, though, especially because facility staff often aren't used to managing acute end-of-life symptoms. The advantage is that family members don't have to do a lot of the caregiving and can focus simply on being there with their loved ones. I hope you found this video useful, and thanks for watching.